but the goal of prevention is for nothing to happen to you. And what we're going to talk about today is going to be my philosophy on why you might take a few medicines so that nothing happens, because most of us get this disease, as you will see. So this is kind of a larger picture look at what harms us. And we spend a lot of time discussing some of these topics, war, murder. We're scared to death of things there. These bubbles are how likely you are to die from each of these conditions. The one that's the biggest here is heart and circulatory disorders, which would include stroke. So really the number one cause of death is heart disease. And if you know what's going to kill you, it'd be good to spend some time preventing it, spend some time inventorying how life is going for you along a path possibly toward heart disease, and how you might make that better. If we look at what are the modifiable risk factors that we can impact to reduce those causes of death, it is high blood pressure. That is an overall risk factor in the world of causing death. High blood pressure is the most important. So there's a lot of things, again, we spend a lot of time worrying about, but this one would be the place to put our public health dollars and really change the outcome of all of us in this room. When we think about blood pressure, I commonly am asked what causes it. And patients come to me and they want to know, why do I have high blood pressure? Thinking there might be one singular thing that we could just go target, and if we did something to that, the blood pressure problem would go away. What causes it is a lot of things. The blood pressure problem that we get, and all of us, as we'll see, really about get it, comes from a number of places in our body. It comes from the way the body handles salt, and the way that kidneys handle fluid. And so it's a buildup of fluid in the blood vessel. There's the tone in the blood vessel. There's how hard the heart pumps. There's things that are in the brain that control a lot of those actual things that affect blood pressure. And then there's hormonal issues that can control blood pressure. So blood pressure is dysregulation usually in a number of areas. It's not just one singular cause. Rarely can I find one singular thing that caused somebody's blood pressure. I saw a patient like that just a few minutes ago in clinic, and it's really fun when you do that, but it's really the needle in the haystack. Most of us get high blood pressure, and most of it comes from a lot of places. And so what we have in medicine is we have targets for each of these places, and those targets, we amass them together until we get you back into regulation, get your blood pressure controlled. So this is some important data. This is taking what we do in clinical medicine is we take large clinical trials where we enroll patients, randomize them to receive a treatment or a different treatment or placebo, and look at outcomes. And we have done millions of person-year assessments of high blood pressure treatment. So we perform trials in people who have high blood pressure. And this data takes a number of those trials, puts them together, and says, what do you get out of your blood pressure? And so it looked at outcomes of death, either from stroke, heart disease, other causes, and amassed 12.7 million person years in clinical trial data. And what is seen is that the ideal blood pressure, if you could choose a blood pressure, would be 115 over 75. So if you look down here, the lowest risk, this is a line of risk. These are looking at age groups because age is the non-modifiable risk factor that we all want to go up. But as you go up in blood pressure, you increase risk for heart attack, stroke, and other causes of death. That risk increases from 115 over 75 such that it doubles every 20 points that you go up with your top number, or the systolic blood pressure, and it doubles with every 10 points that you go up with your diastolic blood pressure. So again, blood pressure is silent. You don't know about what it's doing to you. And when I give you medicines, you usually get angry at me because you think he's taking my money and giving me things that maybe don't make me feel a lot better. But if we control blood pressure, if you cut your blood pressure from 160 to 140, you have cut your risk of stroke in half. And that's pretty powerful. That would be, again, targeting the most important modifiable risk factor and doing something about it. This is ischemic heart disease. I think the previous one was stroke. They all travel the same, such that there's this log linear relationship. This is a logarithmic curve, so that actually the risk goes like this. As you go up 20 points, it doubles. You get to 40, it quadruples. You get to 80, that's eightfold higher. So there's that would be 16-fold higher. 20, 40, 60 would be eightfold higher. So it's in doubling every time you go up. And so blood pressure really can be a valuable thing when it's controlled. You can see a ton of effect that's hard to measure because, again, we're preventing something. But the guidelines from this experience is that, again, there's this 20/10 relationship, such that every 20 millimeters on top, 10 millimeters on bottom, double your risk, which goes the other way. If you cut your blood pressure by 20 or 10, you have your risk. And that held up in people who were older and people who were younger. The younger folks, the risk inclines a little steeper, so you get more benefit relatively, but in the older folks, there is more absolute risk, so there's actually a larger reduction in heart attack or stroke when you treat somebody who's a little older. And this goes all the way down to 115/75. So that's what we learned in the past, okay? The second part of this is assessment of blood pressure. And we do a really poor job of assessing blood pressure as physicians. I will be someone who would say that out loud. Because what happens when you come to clinic? You come to clinic and we're sometimes sticking little sticky tabs on you, we're ripping them off, you walk down the hall, we're in a hurry to get you in the room, and you sit down for just a second and you get a blood pressure measurement. And sometimes you're sitting up in a high chair in the wrong position. And we use that as our assessment tool for something that is the most important thing we can probably do in a cardiovascular clinic. And that's the most important procedure I do is perform blood pressure measurement. The ideal situation is that the patient should be seated calmly in a chair with the back in the back of the chair, feet flat on the floor, and seated for 5 minutes before blood pressure is taken. The arms should be supported at the level of the heart, and then you should take a couple blood pressure measurements. For the initial time that you come to clinic, you should have blood pressure measured in both arms, and thereafter you use the arm that is higher. I like the right arm more than the left arm, and the reason is that the right arm is less likely affected by narrowing in arteries that can occur that go to the arms, and it's a little closer to your central blood pressure. But the right way to measure blood pressure is probably not to come to clinic and measure blood pressure. The right way to measure blood pressure is to do it at home. And we have new guidelines for that that are in our new guidelines. And that is that you should get a blood pressure cuff that works and validate it. And so buy a cuff and then go to the fire station. Sit still in a chair at the fire station. Have one of the fire people measure your blood pressure. Don't move. Have your blood pressure cuff sitting in your lap and measure it again. If it's within 10 points, it's okay. You can use that blood pressure cuff then to measure your blood pressure. And then go home and capture a week's worth of blood pressures. This is a science fair experiment that gives us a number that would really be valuable to know how we treat you. Now, the right way to do that is to do what I just said. Sit still in a chair with your feet flat on the floor, your back in the back of the chair. Sit there for 5 minutes. Sit at the kitchen table and have your arm up on the kitchen table. Put your blood pressure monitor on when you sit down, and then get bored, do something for 5 minutes. After 5 minutes, get 2 blood pressures. You can average those 2. I tend to like the second one. Our guidelines say average them, but people who have white coat hypertension are a little excitable. The second one will be closer to your average blood pressure. We say do that first thing in the morning before you've done anything else, and then before dinner. So those are the 2 times. Do that for 7 days. So you have 7 days of twice-a-day measurements, so 14 measurements, and average those. And if you had that number and brought it to clinic, that would be a number we could hang our hat on and say 115/75 would be perfect, and we're going to see the goals from there. That would be a real useful experiment for all of us to do. So new guidelines, I said November 23rd, 2017, we published new guidelines. The American College of Cardiology is my organization. And these are the guidelines for prevention, detection, evaluation, and management of high blood pressure. A lot of these guidelines came from this clinical trial. So this is one of the most recent clinical trials that you spent your tax dollars paying for. This is the SPRINT trial. It was a trial of about 9,000 Americans who had high blood pressure. And this trial surprised us. So the trial looked at whether we should treat blood pressure really down to a goal blood pressure less than 120. And that's scary, that number 120. Or should we do what we've been doing? And the only place we really had data was that a 140 number was an important number. That was the outline of the trial. Importantly, the trial used 3 readings in clinic using this fancy machine that we use sometimes in clinic. It's a machine where you sit still, again, you program it to wait 5 minutes, it takes 3 blood pressures, and then averages those 3. We set it up and leave the room, so we get rid of a lot of the white coat effect. You can do the same thing at home with what I said, but this blood pressure machine is different than what your doctor is getting in clinic. And we see that when I use the machine. There can be a 10, 20 millimeter difference. In fact, there's a study that shows that blood pressure goes up 8 points when you enter one of our triage units and 12 points when you see somebody with this coat on. And so, again, this was a way to kind of take that away. So you have to handicap this trial some because this is real blood pressure. It's not the factitious stuff that we sometimes treat. Another important thing on this slide is that patients were followed monthly for 3 months and then every 3 months. So blood pressure, it can be a little boring to the primary care doctor or to the cardiologist. It's just not as sexy as some of the other things we do. But if you follow it closely, you can do a lot better controlling it. And so seeing people regularly, and this is going to require what we were talking about in the U.S. today, which is team-based care. It's going to require that we have nurses and nurse practitioners helping us assess blood pressure. In fact, one of the coolest recent trials was a barbershop trial where they measured blood pressure in a barbershop and a pharmacist helped manipulate medicines. It didn't involve a doctor at all, but it got to the people and got their blood pressure under control. So regular follow-up, real numbers in this trial. And what was seen in the trial was there was a group that was the standard group who had an average blood pressure of 136. And then there was this intensive group, the people that we pushed more blood pressure treatment on, who got a blood pressure down to 121. So we kind of met our goals in the clinical trial. What did that mean? Well, if you look here, if you were in the standard group, on average, you took 2 blood pressure medicines. So if you want to get your blood pressure below 140, it takes 2 medicines. If you were in the intensive arm, you took 3 medicines. And that was the average. I mean, some people take 1, some people take 6. And I think that's an important message. But here, if you took 3, you had a difference in blood pressure. This is how well we did. This is looking at actual treatment control to get blood pressure less than 120 or less than 140. And what this shows you is blood pressure treatment is hard. In the U.S. today, we have about a 47% control rate for high blood pressure if we use a 140 number. And so 47% in my kid's grade book is an F. It's not very good. But the best we can do in a clinical trial here to get to below 140 is 71% at the end of the trial. So we're not going to get everybody perfect, but it's important to keep trying and follow people regularly. This was one study, or a meta-analysis of multiple studies that again showed it takes multiple medicines to get there. This shows that on average, in patients in clinical trials previous to this one, it was 3.2 medicines. So this isn't new news. It's going to require multiple medicines and us working harder. But what happens when we work harder? If you're in the intensive group, you are more likely to live. This is mortality. You can't really fake death. And what was seen is that if you really got your blood pressure down, and you had people measuring it monthly, then every 3 months once you got control, you had aggressive use of medications, and you got your blood pressure down, you were more likely to live. And this was an important impact. We use numbers needed to treat in clinical trials, and this was a real important impact on mortality. So that's why we have these new guidelines. So what do the new guidelines say? The new guidelines say that normal blood pressure is less than 120 and less than 80. And so that's where you want to be. That's, again, 115/75 is the right blood pressure. The new guidelines say your blood pressure is elevated if your blood pressure is over 120 or over 80. So 124 is now elevated blood pressure. So, probably everybody in this room has had an elevated blood pressure at one point in time. The new guidelines say if you're over 130 or over 80, you have high blood pressure. So they say that that's a number we should think about really putting people on treatment, as you'll see. They say if you're over 140 or over 90, and this is or, that you have really high blood pressure and that we have to be aggressive about treating it. So this is a shift. If we could show you, I could show you all of our guideline documents. And we really have gotten, with every document, a statement that kind of gets to lower is better. But here with data from a large trial, NIH study, enrolled real Americans, people that look like everybody in this room, and we showed that getting blood pressure down was worthwhile. So we put our words behind our mouth here, or we put our words here behind it, and said we're going to target blood pressure to 130 and 80. So these are our new challenges. What does this mean? It means that high blood pressure is very, very, very prevalent in our country. 46% of America has high blood pressure now. And if you're in the 75 plus age group, it's 80% of America has high blood pressure. So it's ubiquitous. We all have high blood pressure. We all will get high blood pressure. Half of us have it. And so this has made it an important public health initiative to go after this. One important statement is you want to, again, make sure that you're really treating high blood pressure, and you want to get real numbers. So going back to what do? Well, we need to really get a number. We don't want to just use that number that you get when you're kind of running through the triage unit at our clinics. You want to have real numbers. And the reason is that there is this entity that's very common called white coat hypertension. And if you have white coat hypertension, you don't have hypertension, or at least you are not going to see the therapeutic value of all the interventions that I employ like you would if you had real high blood pressure. And so we have said that everybody ought to measure blood pressure at home. And if you come to clinic and your blood pressure is over 130 over 80, then you should put people on some lifestyle modifications, send them home and measure blood pressure. If your blood pressure is less than 130 over 80 at home, then you would be in this boat, and we need to follow home blood pressure, and you need to bring me a week's worth of blood pressures every time you come to clinic. If you get home and your blood pressure is more than 130 over 80, you have verified hypertension, and then you enter our treatment cascade. There is this other entity that we have no capture of in this country, and it is masked hypertension, which means that you love your doctor so much that when you come to clinic, your blood pressure is low, but when you go home, your blood pressure is high. And actually, those people have high risk. They have the same risk as somebody who has hypertension. So it's another reason to measure blood pressure at home, because you might be missing something. And if you brought me numbers, I might think about employing some therapy carefully, and we might lower risk for stroke if you did that. In general, this is the way the treatment algorithm goes now. It is 130 and 80, and everybody gets lifestyle modification therapy or non-pharmacologic therapy. But a lot of people need drugs. And again, there are three major drug classes. There is the thiazide-type diuretic, which is a medicine called chlorthalidone, or there's a sister called hydrochlorothiazide that's fairly good. I prefer the chlorthalidone. There is the ACE inhibitor or angiotensin II receptor blockers. These are medicines that end in pril or sartan, so lisinopril, losartan. You don't want to use these together. You want to use one of these, either or. And then there is the long-acting dihydropyridine calcium channel blockers, which might be a medicine called amlodipine. And what we learned from this trial is these were the most common drugs used in the trial. That if we use these drug classes, we can control a lot of blood pressure. Again, not perfect, but a lot of blood pressure. And so this tends to be our treatment algorithm as we go through things. So what are the non-pharmacologic interventions? Well, they are cutting out sodium. In Alabama, in our resistant blood pressure clinic that I used to work in, we would capture 24-hour urines. And what leaves your body is the same thing as what enters your body. The body keeps things equal. So I can tell exactly how much salt you're eating by doing something disgusting and measuring it in your urine. And in Alabama, when we did that in our blood pressure clinic, we found the average sodium ingestion is 11 grams. I think just breathing air here makes us put salt in our body. But the goal is 2 grams. So we eat 5.5 times what we should be eating in salt. Cutting out salt will lower your blood pressure. Increasing potassium lowers your blood pressure a little bit. Weight loss, every 10 pounds is about 4 points of blood pressure. Alcohol, if you drink more than 2 drinks a day, you're raising your blood pressure. 1 to 2 might be okay. More than that, you're doing something deleterious. Physical activity is good for you. There's a specific diet that we recommend, the diet to stop hypertension. You can Google that and pull it up. It's fruits, vegetables, nuts. It's high in that content. Smoking cessation. Nicotine is a vasoconstrictor. It makes your blood vessels clamp down, and it raises blood pressure. So these things are things to target without medicines. And if you do these things, you can have important effects on your outcome. Just small changes in blood pressure are really important. If you lose 10 pounds, you lose about 4 points of blood pressure. 4 points of blood pressure is a 12% reduction in stroke. And so, that's worth it. And you feel better, but it's really hard work to lose 10 pounds. And then after we employ the non-pharmacologic therapies, what we know is it's worthwhile to aggressively push the medicines. And I may be just kind of speaking on my own bandwagon, but there's a ton of value if we could just use drugs and get people's blood pressure controlled. So again, the way we look at things is you either have normal blood pressure, less than 120 or less than 80. We promote optimal lifestyle habits. We reassess your blood pressure every year, and you get a wellness check and follow-up. You have elevated blood pressure, in which case we ought to employ those non-pharmacologic therapies. Ask you about salt, tell you to cut out the alcohol, and do things right. And we ought to reassess in 3 to 6 months. These are numbers that come from clinic and from home. And then we got the people who have hypertension now. They have blood pressure that's over 130 and over 80. And if you're in a low-risk group, if you're a young person, then we can employ non-pharmacologic therapy and go to the next slide and watch you. If you have some significant risk, then it is worthwhile doing right immediately, employing blood pressure lowering medications and carefully titrating those. If you have blood pressure that's over 140 or over 90, you should take medicines as soon as that is found. That's our new guidelines. If we go to the next slide, if you had lower risk, remember lower risk but had blood pressure 130 to 139 or 80 to 89, then we were supposed to employ lifestyle therapy and get a blood pressure again in 3 to 6 months. If you start therapy, we should see you every month, and we should work to get your blood pressure below 130 and below 80. Those are our goals now, which is going to require a lot more work. Once we get it controlled, we're supposed to see you every 3 to 6 months. This is our new guideline statement. If we do this, A, will be a change in practice for a lot of us. B, I think it will really affect the outcome that we started with, which is stroke. That's the major outcome. And that's the one I can use to scare the snot out of you and get you to do anything I want. So blood pressure control, it's going to take more work, but we need to keep pushing on it. This is our checklist of what we're supposed to do. We're supposed to measure office blood pressure accurately and then get home blood pressure and use a combination of those to make a decision. I didn't mention this, but if you have blood pressure that's sky high or some other interesting things I find interesting, your potassium's low, you're younger, it is worth looking for secondary hypertension. In the people that reek of, I shouldn't have high blood pressure, about 20% of the time I can find a singular cause for your blood pressure. And then we do something about that. We should identify target organ damage, so we look at how blood pressure has affected your kidneys, heart, your brain. We should introduce those lifestyle interventions. We should discuss that the treatment goals are new, 130 and 80. We have a calculator that is an app that anybody can download. It's the ASCVD risk assessment. Pull out your phone and download it. You type in your blood pressure, your age, your cholesterol measurements, a few things you can get out of a wellness check, and you can see how likely you are to have a heart attack in the next 10 years and over your lifespan. It's kind of fun. And if that number's over 10%, then again, we have to think about treatment earlier. We think about our medicines and how they affect other things. So that's drug classes I mentioned. The one in the middle is really good for diabetics. And so there's certain people or certain comorbidities that benefit more from some of these drug classes. We have to account for race, ethnicity, sex, in thinking about our antihypertensive therapies. There's certain antihypertensives that work better in certain scenarios. And then we start drug, we have regular follow-up. We probably need team-based care. We need to have nurses and nurse practitioners, maybe barbers helping us get blood pressure control. We should start connecting you to your telehealth environment, and we should tell you about adherence. Again, measure blood pressure at home, find this thing that's very difficult to find, and do self-monitoring to control blood pressure. This is our checklist of what we should do to get people to where we need to be. So in summary, I think I didn't mention at the beginning, but there is a 90% lifetime risk that you will develop high blood pressure just being alive in this world. The relationship is 20/10, and so if you want to see what blood pressure is doing to you, every 20 millimeters on top and 10 millimeters on bottom that you go up from 115/75, you are doubling your risk for heart attack, stroke, or dying. There is a relationship that if you want to see what you're doing for yourself when you take all these medicines that I just discussed that we're going to throw at you, every 20/10 that you lower your blood pressure by taking a pill, you are cutting your risk of stroke, heart attack, and dying in half. Pharmacologic therapy does work. It, on average, takes about 3 pills now to control blood pressure in people who have problems with it. I think there are 3 major drug classes, and we should get ready to take maybe one from each for a lot of us. Lower is better, as long as you're really targeting a real number. You know, the problem that we have and the fear we have would be if we just, again, get that blood pressure where you're walking in the clinic and you're still kind of huffing and puffing from the walk, and we treat that, and then you go